Hello my friends, my name is Dr. Saeed Kazmi and today I will be talking about hemophilia in children. Hemophilia is what we call as congenital bleeding disorder in children. There are three types of hemophilia: hemophilia A, B and C. A is caused by congenital deficiency of factor 8, B by deficiency of factor 9 and C by deficiency of factor 11. Now A and B, hemophilia A and B are X-linked recessive disorders. What does that mean? It means that the female are always the carriers. They do not develop the phenotype of the illness. The male always get the illness. So the disease would be always present in males. The females do not get affected, though there are a few exceptions. Why the females don't get affected? Because the female have got one X chromosome which is faulty in carrying the genes. The other X chromosome is normal, and that's why they can be silent carriers, but they do not exhibit the phenotype of the illness. But there are a few rare exceptions. For example, in Turner syndrome, which is the XO genotype, in that there's only one X chromosome. So if that one X chromosome is carrying the gene, then that female can develop the phenotype of hemophilia A or B. So there are a few exceptions, but by and large, hemophilia A and B occur in male. Now, how do they present? Because factor 8 and 9, they have to be encoded by certain types of genes, and if those genes are faulty or are missing, or there are some point deletions in those genes, then the production of these factors, which are basically protein in nature, that would be affected. So the liver is not able to make these factor 8 or factor 9 or factor 11, though by and large we are focusing on hemophilia A and B, so we'll be talking about factor 8 and 9. So if the liver cannot make it, there would be either a complete deficiency of this factor, so there is no factor 8 or 9, or there would be reduced activity. Reduced means that the factors are quite less as compared to the normal values. So this could be, for example, 30% of the factor activity, it could be 5% of the factor activity, or it could be even less than 1% of the factor activity. And the severity of the hemophilia is basically based on the factor activity. So if the factor activity, let's say, is less than 1%, we call it severe hemophilia. If it is between 1 and 5%, we call it moderate. Between 5 and 40%, we call it as the mild one. So severe is less than 1%, moderate is between 1 and 5%, and mild is between 5 and 40%. So most of the times the factor activity has to be above 40%, or to make it more simplified, it has to be more than 50% for the child to remain asymptomatic. So this is how we classify hemophilia based on the factor activity. So it can be, and again it is for both hemophilia A or B. It can come in three categories: mild, moderate or severe. Mild means between 5 and 40% of the factor activity, moderate means between 1 and 5% of the factor activity, and severe means less than 1% of the factor activity. Now, how do they present? Because these factors, if they are present in the mother, they cannot cross the placenta. So usually the symptoms, they appear in the neonatal period. And what are the symptoms? Because factor 8 or factor 9, they are actually playing a role in the intrinsic pathway. Remember, the intrinsic pathway starts from factor 12, factor 11, then factor 9, and then factor 8. These four factors are involved in the intrinsic pathway. So what would happen? Let's say normally we do get internal bleeds here and there, but they are usually plugged initially by the platelet. So there is a platelet clumps, we call it the platelet plug, and then the clot stabilized by different types of these proteins, these factors, which go in a cascade manner, and then they stabilize the clot. So if these proteins are deficient or insufficient, then that clot would not be stabilized and they would be having internal bleeding. So the neonates can have severe, life-threatening or life-changing types of bleeds, depending again on how much they are deficient in those factors. So the neonates can have intracranial bleeds, spontaneous intracranial bleeds, or they can have internal bleeds in closed cavity. For example, bleeding inside the abdominal cavity, bleeding inside the chest cavity, bleeding in the pelvic cavity, or bleeding in the joints, which is by and large the most common. So hemarthrosis is the term used for bleeding into the joints. So these children, babies, especially when they start like crawling or something and there are pressures on the joint, they can have spontaneous joint bleeds. So what happens when they got a joint bleed? The joint would swell up. Joint would swell up. So without any trauma, the joint swell up, the child cries because there is pain, and this can happen repeatedly if it goes unnoticed. Nobody thinks about that. So usually where the platelet disorders, they present with more of mucosal bleeding and petechial rashes. The factor deficiencies, factor 8 or 9, they present more with internal bleeds. So usually hemarthrosis is the most of the time the first manifestation which points toward this disease. Or they can have deep muscle hematomas. For example, they've been given intramuscular injection and they can develop deep intramuscular hematoma. So hemarthrosis, internal bleeds, and deep muscle hematomas are usually the clinical manifestations of hemophilia A or B. I'm not saying that they cannot develop mucosal bleeds. They can sometimes develop mucosal bleeds as well, and that can be quite problematic to control. But by and large, the most common manifestations are hemarthrosis and internal bleeding. Now, we have already discussed the severity of the illness based on the factor levels. That, as I told you, that if the factors are less than 1%, we call it severe hemophilia. If the factor levels are between 1 and 5%, we call it moderate, and if it is between 5 and 40%, we call it as mild hemophilia. So severe, moderate, and mild are the categories. So how do we make the diagnosis? Now, the first thing usually is the suspicion of having the illness. So I said, sir, if there are spontaneous neonatal intracranial bleeds or bleeding into the closed cavity, or hemarthrosis without any history of trauma, or even it can happen with minor trauma as well, like severe bleeding into the joint. So then if you do a coagulation profile, you will see that the intrinsic pathway is affected. So the APTT is usually prolonged. Activated partial thrombin is prolonged. So remember here the APTT, right? APTT would always be prolonged. So if the APTT is prolonged, it gives you an indication that the intrinsic pathway is affected, and there could be problem with either factor 12, factor 11, factor 9, or factor 8. Now, normally factor 12 doesn't present with bleeding, diathesis, or is usually asymptomatic. So either you are left with deficiency of factor 11, factor 8, or factor 9. So if the APTT is prolonged and the child has got clinical suspicion of hemophilia or factor deficiency, then the next step would be to do the factor assays. So if the APTT is prolonged, intrinsic path is affected, the next step would be what? To do what we call as factor assays. So we do the factor assays for factor 8, factor 9, and factor 11. As I said, there's no point in doing the assays for factor 12. So if the level of these factors are reduced, then the mixing studies are done. Mixing studies just tries to differentiate if there is a true deficiency of these factors or whether there is presence of inhibitors. So mixing studies are done, and if the serum is corrected by the mixing studies, then it simply means that the child has got deficiency of these factors. So again, because whatever factor is being considered, if that is corrected by adding the normal, that it means that there was deficiency of that particular factor, and the child is then diagnosed with hemophilia, whether that's hemophilia A, hemophilia B, hemophilia C. Further studies, genetic studies can also be done, but for clinical diagnosis, a prolonged APTT with reduction in the particular factor levels, which is corrected by the mixing studies, actually points is good enough for making the diagnosis. So once a diagnosis is made, how do we treat it? Now, this is a million-dollar question. How do we treat it? Nelson Textbook of Pediatrics says that there are two types of treatment. One is what we call as a prophylactic treatment, so which is the gold standard prophylactic treatment, in which you would be, because obviously there is deficiency of these factors, so you have to replenish these factors. You have to inject these factors into the child every now and then at regular intervals. So that is prophylaxis. And the other is on-demand treatment. So one is prophylactic treatment, the other is what we call is on-demand treatment. On-demand treatment means, like for example, if a child for any reason has got a trauma and develops hemarthrosis, or develops internal bleeding, or develops some mucosal bleeding which is not like spontaneously controlled, then in that particular case you have to give on-demand treatment. While prophylaxis means that you simply replenish these factors so the child can lead a normal life without having any bleeding or internal bleeding episodes. So prophylactic treatment and on-demand treatment. Now prophylactic treatment is done by giving these factors. Now where do these factors come from? These factors are made synthetically by recombinant DNA technology. So back a few years back, we had the standard factors made by recombinant DNA technology, which used to have a short half-life. But now we have got the extended half-life factor recombinant factors which are available in the market. So these are given to these kids, and usually, for example, factor 8 or factor 9, they can be given either depending on how much is the shelf life of these factors or half-life of these factors. They can be given on alternate days, or in the extended release form they can be even given on a weekly basis. So the doses are calculated according to their needs based on the what is the actually underlying factor activity levels present, and then they are replenished. So it can be given on alternate day basis, or these days, because we've got the extended life products available, they are usually given every week, and usually because they have to be injected intravenously, usually a subcutaneous, usually a pump is inserted into the child from where the parents themselves can give the factor every week. So the doses, I will come to the doses in a moment. But as far as the on-demand treatment, because it's important on-demand treatment because they can land up in emergency departments, diagnosed hemophilic patients who are already taking their prophylactic medication, but for one reason or the other reason they start having mucosal bleed, or due to trauma, let's say they start bleeding and the bleeding is not stopping. So in that particular case, you need to give them on-demand treatment. So on-demand treatment, again, we have to give extra doses of these factors. So how those doses are calculated? So the Nelson textbook says that for factor A, that is the hemophilia A, the dose, on-demand dose, that would be the desired rate. So if you know the underlying, let's say, factor activity, let's say the underlying factor activity is, let's say, 10%, and you want to bring it to 50%. So the percentage desired rates would be how much? Let's say between 10 and 50, that would be 40. And you have to take the body weight of the child. Let's say this child is 20 kilogram, and then you multiply it by 0.5. So let's say 40 into 20 into 0.5. 40 into 20 would be 800, and you take multiplied by 0.5. That would be what? 400. So you will have to give 400 international units to this child. So you have to take the desired rate. Desired rate is like what is the base level of them for that child, and how much you want to raise. So in most of the cases, we either want to raise it to 50, more than 50%, or in life-threatening hemorrhages, we want to increase it up to 100%. This is what Nelson textbook says. So if like for simple bleeding episodes where the bleeding is occurring but it's non-life-threatening, you want to increase it up to 50% of the factor activity, normal factor activity. While for life-threatening, you will have to increase it up to 100% of the factor activity. So for factor 8, you have to take the desired rate, multiply by body weight, multiply by 0.5. While for factor 9, you just multiply it by 1.3. Rest of the things are the same. So for factor 9, you would be probably taking a little bit more dosage because the multiplication factor is more than 1. There the dose is reduced because multiplication factor is 0.5. So the formula is desired rate in factor activity, multiply by the body weight, multiply by 0.5 for factor 8, and for factor 9 it is 1.3. But let's say if you can't remember this thing, then simply Nelson says that in emergency the dosing for factor 8 deficiency is 50 units per kg and 100 to 130 for hemophilia B. So for factor 8 it's 50 units, for factor 9 it's 100 to 130 units. So let me write, this is for factor 8 and this is for factor 9. So factor 1 is 1, yeah. So for factor 8 it's a 50, you whatever is the body weight, let's say 50 into 20, 1000, okay, body weight, whatever is the body weight. And for, let's say, if it is factor 9, just multiply 100 by, let's say, 20, that will be 2000. So depending on the body weight, in emergency, in life-threatening conditions, if you don't remember the formula, you can just do this simple calculation: 50 for factor 8, 100 to 130 for factor 9, depending on whether you are dealing with hemophilia A or whether you are dealing with hemophilia B. Now, the some of the other, like, doses which you can consider is, again, what are you dealing with? So the Nelson Textbook of Pediatrics says that, for example, in case of hemophilia A, which is deficiency of factor 8, if you are dealing with hemarthrosis, let's say the child has for some reason developed a swollen joint and the ultrasound is showing bleeding inside, then you have to give them 50 to 60 international unit per kg factor 8 concentrate on day 1, then 20 unit per kg on the following day, and then you have to consider every other day until joint function is normal or back to baseline. So if you're dealing with hemarthrosis, 50 on the first day, 20 on the second day, and then every alternate day till the joint is fine. If you are dealing with a hematoma, then you give them 50 unit per kg factor 8 concentrate, and then 20 every other day till function restored. If you're dealing with epistaxis, again, first thing is to apply pressure, and after that you can give them 20 international unit per kg factor 8 concentrate. But before that, you can also consider antifibrinolytic therapy, like, for example, tranexamic acid, topical application of tranexamic acid. For major surgery where there's life-threatening hemorrhage, you have to give these dosages. And for hematuria, again, bed rest, and you have to give 20 international unit per kg factor 8 concentrate. So this is for hemophilia A or factor 8 deficiency. And for factor 9 deficiency or hemophilia B, the doses are slightly higher. As I told you earlier, even when you are doing it through the formula, the multiplication factor is a bit higher. So the doses for factor 9 are higher as compared to doses for factor 8. So this is what the Nelson textbook says about the doses if you are confronted with particular type of hemorrhages. Like, for example, as child has presenting with hemarthrosis, or child is presenting with epistaxis, or child is presenting with hematoma. So whatever is the underlying condition, the dosages or the regimens can change slightly. So you can follow this chart whenever you are confronted with a particular situation of either hemophilia A or hemophilia B presenting with bleeding. As I told you earlier, that earlier in the couple of years back, we used to have the standardized clotting factor concentrate, but now we have got the extended half-life clotting factor concentrates, both for factor 8 and factor 9 as well, and they are available in the market and they are given. So usually these kids are under the hemophilia team, and they give them, they are the one who can prescribe them these treatment. Alprelex is, I think, the commercial name for the extended life factor 9 concentrate, and there are some other as well. And then there are a few other therapies like the gene therapy or some sort of immunological treatment in which different types of immune synthetic immune compounds are given. This is especially when if they develop inhibitors, because inhibitor development is also a very interesting concept in hemophilia. I will come to this in a short while. So coming down to the complications of the hemophilia, remember, repeated joint bleeding can cause chronic arthropathy. So if there is repeated bleeding, what happens if there is bleeding? There would be blood inside. That blood would be then eaten up by, because the immune system kicks in to scavenger cells and the other types of macrophages, they move into that space to eat up the blood, and then there is proteinolysis. The proteins are broken down, and there would be the cells, the inflammatory cells would come into that area. So if that thing happens on a repeated basis, what would happen? The synovial membranes would be damaged. It would lead to chronic inflammatory changes that might even lead to degenerative changes. You can have like secondary osteoarthritis, degenerative arthritis, and long-time problems leading to deformities of the joint. So it's very important that the child should not reach that state. So whenever they have got bleeding or something, you should promptly treat it, and then a strategy should be made that they should not have bleeding, so that their factors are always kept within normal level, so that they do not have these types of episodes which would prevent the chronic arthropathy in the long run. So it's very, very important that these kids, and if they have developed chronic arthropathy, then they need to have a multidisciplinary team, especially physio and orthopedics, to look into that as well. They might need some form of reconstruction of the joints, which again would be multidisciplinary, or they might need physio to sort of regain back their physical strength and mobility. Um, a few things more, like in certain types of bleeds, both in hemophilia A and B, remember you can also give antifibrinolytic therapy. For example, tranexamic acid can be given to these children, especially if they've got mucosal bleeding. For example, epistaxis or bleeding somewhere from the throat. Sometimes nasal desmopressin can also be given, which is actually a vasoconstrictor, and that also helps that way, though the pathways are slightly different. The other thing is that these vasopressin also helps, sorry, desmopressin also helps to cause increase in the endogenous release of factor 8. So whatever stores are there, it would help the body to release that factor 8, and that can also help in in controlling the mucosal bleeding. There are a few uh, other therapies, gene therapies, in which they use these days viral vectors to address hemophilia A and B. So these are targeted gene therapies in which genes are introduced through a viral vector, and they are experimental things with sort of a plus and minus type of results. By and large, there are specialized centers which deal with these things, which probably as in an emergency department you won't come across, but in an ED setting, you should be more focused on controlling the bleeding and replenishing the factor so that the acute episode is addressed, and then the follow-up management can be done by the hemophilia teams or by the hematologists themselves. Now, an important concept in hemophilia is the development of the inhibitors. So those children who are repeatedly getting these factors replacement, after some time what happens is that they develop inhibitors. So let's say if you come across a hemophilic child, a diagnosed hemophilic child who's having a bleeding episode, and despite, and you do, let's say you are able to do factor S's, and the factor S's, let's say, are above 50%, and the child is still bleeding, and you have given factor concentrate as well, and even that is not working. In that particular case, you should be thinking of inhibitors presence, and usually after 20 administrations of, let's say, factor 8 or factor 9 concentrate, there is some form of inhibitor development in the blood. So these inhibitors themselves have to be inhibited, and there where the immune compounds they come into. So one of the immune compounds which is quite uh, efficacious in dealing with this type is emicizumab. So emicizumab is basically an immune product, and it is quite efficacious in addressing the presence of inhibitors. So if a child who is hemophilic, who's got bleeding episode, but his factor assays are above 50%, and he's still bleeding, and you're scratching your head that what is causing that, remember that could be due to the presence of inhibitors. And to overcome that problem, you have to give them either they will require higher doses of the factor concentrate. With that, you can also give them these immunologicals, emicizumab. So emicizumab can be used to treat the presence of inhibitors in hemophils, whether it's hemophilia A or hemophilia B. caused by deficiency of factor 8 or 9 respectively. So this was all about the hemophilia A and hemophilia B. Why this happens, what are the underlying genetics, what are the common clinical presentations, how do we diagnose it, like how do we suspect it, how do we diagnose it, and then how do we treat it by replenishing the factor 8 or factor 9 respectively, what are the doses for these factors, and what are the special circumstances in which there could be the presence of inhibitors and how to deal with those situations. So I hope you have understood the basic things around hemophilia A and hemophilia B in children. If still have got any questions, please feel free to ask me questions. I'll be more than happy to answer. So have a very good day. Take care and bye-bye.